Hi, everyone. We'll just give a few extra seconds for everyone to log on and get situated, and we're excited to get started. Okay. Well, good afternoon, everyone. Thank you so much for joining us for today's webinar. The research results are coming in. Providence Living at the Views, co-hosted by CARP Ottawa. My name is Tiffany Fearon, and I'm the Policy and Impact Director at Family Councils Ontario. Before we begin, I would like to acknowledge the land on which I am joining from today. I'm in Mississauga, which is situated on the traditional territory of the Mississaugas of the Credit First Nation. This land is part of the territory covered by Treaty 14, also known as the Between the Lakes Purchase, and is now home to many diverse First Nations, Inuit, and Métis people. I also recognize that many of you are joining from different places, and I encourage you to take a moment to reflect on the traditional territories where you are located. So before we get started, we wanted to share a few logistics and housekeeping rules before we turn things over to my CARP co-host, Carol, who will introduce our speaker. You'll notice that all participants are in listen-only mode. We reserve time today at the end for an interactive question and answer period. At that time, we invite you to use the Q&A function, the box below, to ask your questions to the guest speaker. I will come back with our co-host, and we're excited to be able to facilitate a great Q&A section. Please use the chat feature only if you have any technical issues. For your information, today's session will be recorded and will be made available to participants on Family Councils Ontario website and YouTube channels. It's my great pleasure to pass the floor on to my co-host, Carol, who will introduce our guest speaker. Thanks, Carol. Over to you.
Thanks very much. I'm very pleased that so many of you have been able to join us. Those of us at the CARP Working Group for Long-Term Care have been for a long time trying to encourage, influence, beg, borrow, steal, and get homes to do the innovative models so that how they approach things is through emotion-based or person-centered care, resident-centered care. You've heard a number of topics, but they're all the same. The resident guides and leads how they do the care. But to make that better, easier, faster, both for the resident and for the people that work there, we're advocating and trying to convince the people that support long-term care is to build small homes so that you don't have great big institutional buildings like we know and have seen for years. And it's really exciting to go out to BC and hear what they're doing out there, and we can bring some of their ideas. Dr. Amy Salmon has got lots of extensive research capabilities, and she's been a frontline worker. She's been a healthcare administrator. She knows what needs to be done. And the fact that she's been able to lead this 5-year funding research is what we're all waiting for, is some of that hard data as to, we know that the smaller homes works better. And makes everybody happier, brings joy, brings independence, makes living in long-term care worthwhile. But we want to hear how it does it, and so that people can adapt the idea in their home. So Amy, we're really interested to hear what's going on. I know that your data is not solid yet. You're still gathering data, and I'm sure you'll share when you've got some real hard facts to let us know what's going on. But take us on your journey with us. Thanks.
Thanks so much, Carol. It's a great pleasure to be here, and thank you everyone for making the time to join us for this conversation. As I'm sure you expect, I'm just going to take a moment to pull up a slide deck for us. There we go. All right. Okay. Carol, can you see my slides? Are they showing just fine?
Yep, they're good. Yep.
Great. Thanks very much. Okay. So, as Carol mentioned, I'm going to be sharing with you some of our learning that encompasses the period of time up to the end of the first year of occupancy at Providence Living at the Views. I'll tell you a little bit more about both Providence Living and the Views as we go on. But just to give you a sense of what the building looks like, you're looking now at the front door of the building. You're seeing on the bottom left side of the corner the children's daycare that's part of the Views. Just above the front door, you're looking at a big, large deck, and that deck is part of what gives the Views its name. The Views is located in the town of Comox on the east coast of Vancouver Island on the traditional and unceded territory of the Comox Nation. And when you stand out on that deck, you get a beautiful view across the ocean. And that view extends to the indoors into the bistro area and the community center. I'll tell you a little bit more about what you find when you come for a visit once we get inside. I'd also like to acknowledge and express my gratitude to my colleagues whose work is essential to the conduct of our evaluation, including Doctors Easterbrook, Iamu, Sawatsky, and Chowdhury, as well as the extraordinary research staff that we've had a pleasure to work with, including Ms. Banjo, Ms. Gamagi, and Ms. Zhang. I thought this might be the first time that that some of us in the room are encountering the Center for Advancing Health Outcomes, and so I also thought I might just take a little moment to let you know about our research center and where we're coming from. So our center is jointly part of Providence Healthcare, which is the parent organization of Providence Living, which owns and operates long-term care homes. The Center for Advancing Health Outcomes is also a center of the UBC Faculty of Medicine. We were established in 1998 as a group of researchers who were very dissatisfied with ivory tower academia and wanted to be doing applied work in the heart of the healthcare system where we felt we could make a difference to both improving the lives of patients and their families. Now we're also working with residents in long-term care, and of course, to ensure that we have a health system that is robust, that is future ready, and that provides us with the mechanisms and supports that everyone needs to ensure that decisions about care can be made on the best available evidence. We're a medium-sized research center with about 100 members of staff and about 82 scientists, of whom I am one. I'm also the director of the center. So now we're looking at the inside of Providence Living at the Views, which you'll see on the bottom corner. Providence Living itself is both a registered not-for-profit and a registered charity. It was formed in 2017 with a deep desire to completely rethink and reimagine the experience of older adults who come into long-term care homes. Indeed, replacing the concept of care home as institution with a genuine community. I've had the very great pleasure of collaborating with Providence Living since that time, both on this specific initiative to develop the Views and with others who stemmed from it. Now, the Views is deeply inspired by, but not identical to, the Dehogovic care concept, which you may also have heard of as a Dementia Village model that comes to us from the village of Visp in the Netherlands. To the best of our knowledge, it's the first concept of its kind to be implemented in a fully publicly funded system. We know, of course, that there are models of that are very similar, including some in British Columbia, that are also inspired by the Dehogovic care concept. And we do work closely with those care homes. The real initiative here, though, was to understand if, when, how, and under what conditions such a model could be implemented in care homes for people who cannot afford the $8,000 to $12,000 a month that it costs to live in the private sector version of this model, at least in our province. There are 156 beds in the views, but those beds are all found in separate bedrooms in groups of 12. And so we have 13 households with 12 beds in them. This also includes a couple of dedicated suites for respite, so people do not live there but might come for short periods of time, and also 2 suites that are meant to accommodate couples. I'll take you on a little tour of the inside as well, so you can see, looking at the bottom photo, that the views is sort of shaped kind of like an oval. And inside that oval, so you enter through the ground floor and you take the elevator up to the second floor. Um, and when you arrive on the second floor, this is a large part of what you see. What's not pictured here, it's just outside of the corner, is the Indigenous healing space that is maintained by Comox Nation for its members. You're seeing a chapel here. We have an outdoor barbecue pit area. You also don't see, well, you're seeing, I guess, the little corner here of a children's playground. This is really intended to break down those barriers that we often find between long-term care homes and the larger community. So the bistro, for example, invites people from the larger community in to come and have a cup of coffee and visit. The inside area has become a place of choice for families with young children who want to sit outside and have a cup of coffee. They may have no connection to the views, but or to the residents there, but they experience this as a safe and welcoming place for their kids to run around while they can relax, where their presence is welcome. And you can imagine the kind of life that that breathes into a long-term care home that we don't often see. Now, as an evaluation team, this was also an exciting opportunity for us to really look at the impacts of innovation in action. We could not have asked for a more research-friendly approach than what we have here. You'll note here that on July 8th, 2024, the care home opened. Now, this care home is located on the same piece of property as the previous care home, which came out of a repurposed hospital that was built in 1938. If you'd gone to visit what we'll call the old views, it would look very much like many of the long-term care homes that I'm sure you're very familiar with. The care was good. The people in the home were very compassionate, empathetic, concerned with ensuring that their care meets the highest possible standards that could be achieved. But the facility itself had aged to the point that it was no longer suitable for its purpose. In fact, we might ask whether it was ever suitable for its purpose, as many of us do when we visit these spaces. The buildings are often what are available to health authorities or to nonprofit societies, but the standard configuration in the old building would have looked much more like an antiquated hospital room with 4 beds separated by curtains, not a lot of privacy, all shared washroom facilities, for example. In the new views, as I mentioned, everybody has their own, in their household, they have their own private bedroom and their own bathroom. All of the accessibility equipment is in those rooms so that if people have a condition that results in a progressive loss of mobility and might require things like an overhead lift or accessible bathing facilities, all of those are included in the private rooms. In addition to those 12 private rooms, each of those households, and that's a term I'll use to refer to each unit as we go forward, each household has its own kitchen. It has its own living area with a television and a fireplace, and its own dining room. So there's a mix you can see here of public space that we can move around in, like this outdoor courtyard, and then the private space of the bedroom, and then the semi-private space of those shared household facilities. Now, on that day, July 8th, 2024, we had the great experience of being able to see the same group of residents who had been living for the 2 years in which we've been collecting baseline data in the old views, as well as all the staff who have been working in the old views, come across the parking lot over a period of about 4 hours. The photo that you're seeing at the top is the first resident to be welcomed into the views. All residents were welcomed into the new home in the same way. And so we had the perfect opportunity to use sort of a real life trial design to see what happens for residents, what happens for staff, and what happens for the health system when we move this group of people from one place into the new building. Now, oops, there we go. Okay. As our evaluation team came together and started to develop the protocol, we were really struck by the opportunity that was being offered here by Providence Living to really demonstrate what we feel is courageous and compassionate leadership in seniors care, as well as a commitment to embedding evaluation, not just at the end, so we could see what happened in the end, but all the way along, so that as we were collecting data in the period before the move, we could feed that information forward to help with the design of both the physical environment and the new model of care, to engage residents and staff in sharing their opinions and needs for this new space. And our challenge was really to capture, share, and analyze meaningful data in real time to support the system transformation that was on offer. Now, another very important challenge that we have in this is that being that this is the first independent comprehensive evaluation of the model in Canada, we thought we might require some adaptations. But in fact, none of the instances of the Dehogovic care concept that we're aware of, and I've listed on the slide here, the countries in which these care homes are currently operating, have been subject to an independent comprehensive evaluation. And we have no benchmarks to compare with. So we were also really challenged to think about how we could design our data collection and analysis systems to be relevant for the health system that we're in, but also to provide results that could be shareable elsewhere. Now, this work, I think, as Carol alluded to at the beginning of the session, is very much grounded in the broader movement for culture change in long-term care, where we are moving away from those institutional, highly medicalized models towards relational or community-focused models. These approaches to care are fundamentally grounded in shared values of the culture change movement that include, first and foremost, a respect for and a prioritization of resident choice, of dignity and respect, taking a holistic view of wellness, as well as fostering close independent relationships, purposeful living, and enabling environments that support all of these things. So we're going to talk about this as one example of a social and relational model of care. So I thought I would take a moment to define how we're using these concepts in the context of this work. So a social model of care here is one that would be contrasted well with what we might think of as a medicalized model of care. In a medical model of care, it's really a diagnostic lens that drives interpretation and understanding of people's experience of living with disability or a chronic or progressive illness. And so when we would look at things like difficulties that residents might be experiencing in the context of a care home, we would often look at those through the lens of their diagnosis. In the case of the views, we have about 70% of the residents who are living with dementia. And this is one group that becomes particularly vulnerable in overly medicalized institutional models. In this instance, people with dementia often have their expressions of need or distress interpreted through their language of their diagnosis and saying, well, they feel this way because they have dementia, or this is a symptom of their illness, rather than possibly a reasonable response to living in a very challenging, uncomfortable, or difficult situation. So in a social model, we often look to factors within the environment, which could include the physical environment, but also the policy environment, and how these external factors shape people's experience of living with their health conditions and provide an opportunity for supportive intervention. When we look at relational models of care, this is really about fundamentally, as the term suggests, emphasizing that the primary task of a long-term care home is to build meaningful, supportive, empathetic relationships between those who are providing care and those who are receiving care. And so here we see a confluence of values that support that work. Just thinking about the comparison to a relational model of care, we often think about task focused. So it's not about me building a relationship and through that relationship, understanding how best to care for an individual person. Instead, if we're looking at task-based models of care, it's really the clock that is often the driver of the day. So here's one example of a model that we created of task-based care, looking at our baseline data from the old views. So for example, in a task-based model here, we see our shift start at 7 a.m. The staff have their quick morning huddle. It's maybe 7:30 or maybe 7, with the shift starts at 6:30. And then staff go about their day of doing morning personal care for those who are waking up. And so in this case, if you're a person who lives in one of these care homes, the time that you might wake up in the morning isn't something that you would choose. It's something that's decided for you based on when breakfast needs to be served and the time that it's going to take to get care staff to get everybody up, washed, maybe to the washroom, dressed, and out to their room, or out of their room into the dining room. Then we can see as we move across this model here that the task-driven model really does not serve the residents or reflect what residents might want or need. I, for example, am an early riser now because I have to get up early for work. But when I have a choice about when I get up in the morning, I might need to get up a little bit later, and I don't necessarily want to eat right away. When we transition to the household model, as I'm about to show you, that's where these things become more possible. So I mentioned those shared values that underpin the culture change movement and social relational models of care. In the context of the views, those values and priorities are expressed through their model of care, which is called Home for Us. Home for Us has as its guiding principles that are what I would consider as an evaluator to be outcome based, and those are the ones that are represented in this purple color. So here the values are that residents direct each moment, so not the clock, the need of the person who is living in the care home, the people, and recognize that those needs may be different. Also, that emotional connections matter most. So while it is absolutely the commitment of Providence Living to ensure that each and every one of its residents receives the highest possible standard of clinical care that's indicated for their particular condition, the primary job of the worker is understood to be to build that relationship, because it is through that relationship that often improvements can be made to clinical decision making, amongst other things. The third value is idea that home is not a place, it's a feeling, right? And I think all of us who have spent time in long-term care homes, particularly care homes for people who live with neurocognitive conditions, have experienced or seen the distress of an individual who might be pacing about the home, saying, I want to go home, I want to go home. And yes, some of that experience may be due to the person's neurocognitive condition, but there is a lot that we can be doing in the context of that condition to help people feel like they are at home. And so a great focus of the work here is on that, ensuring that that commitment is met. The mechanisms that are used for decision making here are often human-centered design and relationship-based care. I'll also note as we go forward that the slides here contain images of residents at the views, and they're all included with the explicit permission of residents and their family members to do so. So, um, you've heard that we have a 5-year evaluation plan. 3 of those years were spent collecting baseline data, preparing and then collecting those data in the 2 years prior to the move at the old views. And the data that I'm going to share with you today is a summary of what we've learned in the first year since occupying the new building and working within the new model of care. If I were to say what our overall experience in the first year of working specifically within this model of care, I would say that we've learned that the Hogovic care concept is certainly very well aligned with the mission and values of an organization like Providence Living, perhaps also with the values that many of us on the call here would share. But implementation of this model required far more adaptation and innovation on behalf of both leaders and direct care providers at Providence Living than was originally expected. Now, we worked very closely with the Be Advice team from the Hogovic and really benefited a great deal from their advice and their encouragement over time. But fundamentally, there are some very different structural realities of how healthcare and long-term care delivered in British Columbia that set us apart from the context in which the Hogovic was built. For example, this care home is located on Vancouver Island, and Vancouver Island has its own regional health authority. That regional health authority maintains a centralized wait list. So you could be living anywhere on Vancouver Island, which is 500 kilometers long and about 300 kilometers wide at its widest. And when you qualify for long-term care, you can identify up to 4 care homes of choice, and you can refuse once when you are offered a bed. So it's this first available bed policy, and a centralized wait list means that the Views doesn't have the opportunity to look in the more contemplative way that the Hogovic is able to do, to think about things like household composition. So they can think about, does this care home as a whole have the capacity to offer the sort of care their prospective resident needs? But in the Hogovic care concept, they really do focus on lifestyle and other personality factors of residents when thinking about how they group them into their households. And here we don't have the opportunity to do that. Sometimes we can do a little bit of shifting around, but really, in this care home, and as the case of most of our publicly funded care homes, we have a wait list of 7,000 people in British Columbia who are waiting for these beds. And so a bed is a bed is a bed. And so the staff go to great lengths to try and ensure that people can be accommodated where they are. Another structural factor that's made it difficult to implement this model is that British Columbia is still using the funding formula of 3.36 direct care hours per resident per day. So far short of the proposed national standard of 4 or 4.2 direct care hours. This is also an average number of care hours per resident per day. So, so some residents may require more, some residents may require less. But this has made it very difficult, particularly to ensure that some adequate support is available to assist residents in participating in the broader life of the community, because staffing is very thin, and that funding formula is really based on a task-based focus. Finally, we're working in this case in a context where the educational preparation for people who are coming to work in this model of care is also based on that task-based practice. Because in recognition of this, the Views right from day one has welcomed trainees, both in the healthcare aid training programs and in the LPN, RN programs, as well as medical residents to come and learn to work differently within this model. Oops, there we go. Okay. The next important learning that we've had is that at least in that first year, some of the biggest changes that we see in resident quality of life and well-being, I think, are really attributed to the built environment. So we'll have to wait until later this summer when we have our economic evaluation completed to be able to say for sure where we got the most bang for our buck in this investment. But the but certainly, if we're looking just from the perspectives of people who are living at the Views, the change in that built environment, including the privacy of their own bedroom and bathroom facility, the ability to use a kitchen. This is one of the lovely residents at the Views who loves to do baking for just about every holiday. And so she's often the first one, up and ready to start doing the Christmas baking, and has the ability to do that. Whereas in the previous care home, residents had no access to a kitchen, and neither did their families. And so the opportunities that this creates, I'm sure you can appreciate, are numerous. Having unencumbered access to that outdoor environment of the courtyard that I showed you has also been incredibly important. And we can see that quantitatively when we get to the impacts on quality of life that we've measured. Thankfully, we're also finding that with this new built environment, that the era, at least at the Views, of having a completely shut down, sequestered home when outbreaks occur, as we saw most notably during the height of the COVID pandemic, is now a thing of the past. We have the ability now to care for residents who are quite ill in their rooms. And also where the occasional infectious disease outbreak may occur in households. Thankfully, that's not particularly common. But when it happens, if there is a need, having the care home organized around a household model makes it possible to quarantine one household without having to quarantine the entire care home. Here, looking at a structured assessment of the built environment, we see the same outcomes. So in gray on this bar, you are seeing data that was collected in the old Views at the Ocean View unit, which was the locked memory care unit. And then in blue, you are seeing the scores for Orca household, which is one of the households that happens to have the largest representation of people living with advanced dementia. And as you can see, on just about on every axis that you would care to look at on this structured assessment, we saw massive improvements with the change to the built environment along many of the axes that are most important, both for residents and for their families. However, we would note, though, that the impact of this change, and particularly the ability to enjoy these quality of life benefits, that can be achieved by built environment changes are really dependent on individual capacity and the ability to provide support, relational support. So, as you can imagine, those residents who are able to move around the space relatively independently are able to enjoy many more of these built environment changes outside their household than those who require more assistance to get around. With that 3.36 care hours per resident per day, the ability to enjoy some of those communal spaces. So not just the outdoor area, but also the community center, the bistro, the art center, the gym and wellness facility, or to organize a group in the multipurpose room depends on having the additional staffing available in order to assist residents to go to the space or to be able to stay with residents in the space to support personal care needs. And that isn't always available. And so again, this is not a fault of the care home itself. It is a structural constraint of the system in which we find ourselves currently. Now, I'm just going to skip ahead here, and I'm going to talk to you about how we measure quality of life for residents. So the views, like many of the care homes that I'm sure you're already familiar with, are use the Inter-Eye system and collect data through that platform. However, the Inter-Eye system is all proxy report. Some care homes use do this directly with residents, but in British Columbia, most care homes are using proxy reports. So this would often be the report of a staff member who knows the resident best, sometimes a family member. We introduced two tools, and this is one of them, the McGill Quality of Life Questionnaire, which is a Canadian-made quality of life measurement tool for people who are at the end of life. And we recognize, of course, that not everybody who lives at the Views is immediately at the end of their life. But we found that some of the constructs of this questionnaire, as you see listed here, map on quite well to the social relational goals of the model of care. So there's 4 dimensions of the McGill Quality of Life questionnaire. Physical dimension, so how are you feeling physically in your body? The psychological dimension, so are you worried, nervous, depressed, sad? Do you feel fearful of the future and what your life might hold for you? There's an existential domain, which is about having achieved meaning and purpose in one's life, the extent to which a person feels that they are achieving their life goals, their sense of personal control and autonomy over their decision making, and their sense of self-esteem. Do I feel good about myself as a person while I live in this place? And then finally, the social dimension focuses on aspects like how easy is it to communicate with the people that we care about the most, the extent to which our relationships feel stressful, and the extent to which we feel supported. All of these questions are asked of each resident on a quarterly basis who has, and this tool is validated for individuals who have what we consider a moderate dementia or below. And so it made it possible for us to have all residents on one tool, which was very important to us for comparative purposes. Now, given the commitments to this model of care and the focus of the transformative effort in moving away from that institutional care model, the predictions that we all made at the beginning was that we would see some of the biggest and immediate changes on those social and possibly existential dimensions of the tool. We did not expect that we would see, and then of course, we expected to see changes in the psychological dimension. We did not expect to see any particular changes on people's physical quality of life. But in fact, this is what we found. So we're using an interrupted time series design. I'll explain to you a little bit what you're seeing here on these graphs. So an interrupted time series design has as close as we can get to the methodological strength of a randomized control trial without the ability to randomize individuals to one condition or not. What we do instead is we ensure that we collect a sufficient number of data points prior to the anticipated change and a sufficient number of data points after the change for us to be sure that any change in trend that we see over time is most likely attributable to the intervention itself and nothing else. So the dotted vertical line that you see on each of these graphs is the point at which that move changed. This is July 8th, 2024. The red line is data that we collected from 5 comparative care homes, all operated by Providence, but not part of this intervention, in that they did not receive a new building with a household model and the same changes to the model of care. They were, however, care homes that are all overseen by the same leadership and have very similar resident compositions. The blue line is the views. So in the top left, you can see, quite interestingly, that the first change that we saw was a fairly dramatic change in a downward trend, people's physical well-being, to a trend that has us going up and up and up. Comparatively, actually across all 4 domains of this particular instrument, you can see that those trend lines in red for our comparative homes are relatively flat, which is what we would have expected. The next change that we saw was a change on the psychological. The next change we saw was on the existential domain, which had an immediate upward trend, but has since flattened out. However, that trend is quite distinct from what we were seeing previously. And so again, we can see that that existential change is attributable to the move. We have yet to see a meaningful change on the social dimension, which is a bit surprising to us, and we think there may be some reasons for that. On the psychological domain, we saw an initial dip, which is part of a very well-observed phenomenon in long-term care that's called relocation stress, where often the transition from one physical environment to another is emotionally a little bit difficult. But once residents adapted to the new environment, again, we saw those upward trends. So where are we? So we still have a lot to do on this evaluation, and I'll be excited to share the final results with you at the end of this calendar year. In the meantime, though, Providence Living sure is not resting. They're very committed to ensuring that this model of care at the Views was not one flagship home and that was a one and done pilot project that then is at risk of sort of suffering death by pilot project that many of us see across this sector. Instead, we have 3 new homes, 2 new builds, one in northern British Columbia and one in Vancouver, that are inspired by this model. In addition, renovations have been made inside an existing care home to allow for 1 small person household there. And we're doing evaluation in all of these spaces. Now, I realize I'm a little bit over my time, so thank you very much for your extra attention. I'm going to stop sharing now and look forward to your questions.
Hi, Amy. I don't know if you can hear me. It's Marg.
Hi, Mark. Nice to see you.
Right. I just wanted to thank you for sharing that information with us. And just a couple of comments while I wait for any questions to come up on the chat line there. One thing that you said really kind of stuck with me is the job of the worker. You talked about home is not a place, it's a feeling. And I think that's a wonderful line, and I hope to use it in some of my conversations afterwards, because I think it's perfect. You talked about how you came from the old building and moved on a moving day, and it took 4 hours. In the old building, so I got a couple of thoughts about that. In the old building, were you still doing the model of care, home for us model of care, or was it more task-based? That's my first question.
Mm.
And the second, in relation to the day of the move, was what did the residents feel like and experience when they got into their new environment?
Yes. Okay, so first, in terms of the old building, I guess what I would say is that from an organizational perspective and from the perspective of most staff, there was lots of buy-in for these principles. The challenge is that staff had never had the opportunity to work in a place that modeled this. So because of that, of course, there are, some ingrained habits that can persist, and also some limitations of the built environment that made it very difficult to fully realize many aspects of the model. So I'll give you just one example. In the old care home, there were a limited number of accessible bathing rooms. And so because and really just one tub per unit, and those units were quite large, so more like 30 to 50 residents. And so because of that, the organizational culture, and this was something that was in place before Providence Living actually even took over the operation of the home, was that they had a bath team. So each resident had a scheduled bath day. You would have a bath once a week, and it would be at your scheduled time. If the time when the member of the bath team arrived to collect you, it was not a good time for you to have a bath, you'd have your name written in the missed bath book. And then if and when there was time in the day that a healthcare aide could slide you in, you might be able to have another bath. So that to me is quintessential task-based care. And I'm very happy to say that's gone the way of the dodo. In terms of the resident experience on that moving day, for the most part, I'd say residents were very excited about the space. They'd really had the opportunity to follow the project along because they saw the building coming up. Many residents who have the mobility to be able to move through the space also had tours through the homes before they arrived. So they had a bit of a sense of what they might be coming to. But even so, I would say on moving day, the what I overheard most often is, do we get to stay here all day? Or what time do we have to go home? It was the sense that this place that they were visiting was just so unlike what that they were used to. Took some residents a little while to become comfortable with the fact that this was their place and they wouldn't have to leave.
Yeah, wonderful, wonderful. In terms of evaluation, and I know that there'll be a lot more results coming down the pipe as time goes on this year and probably next. Interesting about the inter-RI, which I guess all homes use. There is a bit of a social element evaluation to that tool. What we had discovered in some of our digging around was that not all the homes actually use that section of the inter-RI because they weren't required to. Am I right on that?
Yes, that's right. I think that might vary from province to province as well in terms of what homes report into the minimum data set. But yes, there's certainly many modules, including the social module of the inter-RI. They're either not used or they're underused. Yeah.
Right, right. So it's very hard then to look at quality of life unless you try a different measure or two as well, like you're using the McGill model, which is interesting. And it is fascinating, as you've said, that the physical aspect improved. So was that ambulation? Was that what specifically did you see in that?
Yeah. Certainly, I think ambulation and just the ability to walk freely around a space is made a huge difference. Just about every day now, we can go into that outer courtyard that we've seen, or into the bistro and the community center, and you'll find residents there on their own or in small groups, maybe having a coffee, maybe having a little saunter around. There also are a number of community groups who come in and use the space for their own activity. So, for example, I have a family member who is part of a community choir, and they come and use the chapel at the Views because it's got great acoustics. And they love to practice there. But then that's also a great incentive for some residents who want to just come out and hear a choir sing. There's reason to get up and go. That's a little bit different from just going back to the same room where you eat your breakfast, lunch, and dinner to play bingo.
And that's the purposefulness that you related to previously. Yes, absolutely.
Exactly. And I would say that, again, here's where built environment and structure also matter more than we might give them credit for. So I, for 2 years, interviewed residents at the old Views. Never during that time could a resident tell me about the last time they went outside.
Oh,
And I don't think that that's because every resident was not going outside, but it was just not a regular part of their day. The old building was built as an acute care, a small rural acute care community hospital. It was not intended for people to live 24/7. And so the closets that residents had in the room were those small hospital closets.
yeah.
So I talked to family members and they'd say, well, I can't keep mom's winter coat in her closet because it would take up the whole space. So I keep her winter coat and I have to remember to bring it with me if I want to take mom out for a walk in the colder weather. And so I think even things like that, we don't necessarily think of the cumulative impact of these kinds of small decisions, but I think they matter much more than we give credit to.
Right. So I think it's amazing that Providence Living at the Views has been able to do this. And especially in a publicly funded place, because we all knew how much the private one cost and how it was difficult for most people to afford that. So what do we need to do to move this across the country?
Yeah. Well, I think even so in terms of affordability, I think we are all of us rallying around that national standard of increased care hours. We think that the real number for being able to sort of fully realize this model of care in British Columbia is also in that sort of 4.0 to 4.2 would be ideal. If the Views was at 4.2, then we could almost always ensure that there is a care aide who could accompany a resident to their chosen activity, which is important again because structurally, the rec and leisure aides who run the activity don't have within their job scope the ability to provide personal care. So if a resident were to not be steady on their feet, or if they needed assistance to use the washroom, that would need to be a healthcare aide who would come to those. But we don't include that in the healthcare aid hours. So I think the more that we can do to unite around this national standard, the better we'll be able to realize flexibility in our systems to achieve whether it's this model or something else. I also think that we could really be doing a lot more, all of us, to emphasize the importance of quality of life from a broader, more person-centered perspective.
Right.
All of our national indicators right now focus on quality of care. And that is a very important piece of quality of life. But none of us experience our best quality of life only in consideration of the medical care decisions that are made for us, right? That is the bare minimum. But I don't think that's what we want our systems to be aspiring to.
Let me just ask you this. I agree with you about the number of hours of care. And in Ontario, which is where I'm located, it is over 4, which helps, but it doesn't solve all the issues. And so in your opinion, then, if there was a home that was not a small home model, is the barrier the building? There's I haven't maybe asked it right. Is the barrier the building environment?
No, I understand what you're saying. To be honest, I think the building is an incredibly important facilitator. We still, just as an evaluation group, sort of want to reserve the right to keep a question mark hanging over that, because we're very curious to see what's happening at that home in Vancouver, Uville, that I mentioned at the end,
Right.
where there is one 6-person household that's been built, but all of the other assets of the care home are, have remained unchanged. And that's just simply because of a lack of funds. The hope is eventually we have household models everywhere. But what that household model, I think, enables that we don't see in those larger congregate settings are those opportunities to express personal choice. And also, I think achieving that initial jump in that physical domain of the quality of life was really about that purposeful living and the ability to go to different spaces. So I guess it's to say in the first year, that new building seems to matter more than we hoped it would. We'll have to see whether those gains continue through year 2, or if there's sort of just that first year effect that where things jump up and then they plateau after that.
Well, it's been really interesting to listen to you, Tiffany, and we wish you all the best as you carry on. I hope that we can have you back in a number of months down the road to gather more data. And so thank you so much for sharing your experience with us. And I'll turn it over to Tiffany now.
Thank you.
Thank you so much, Mark, for handing it over. And Amy, this was a very inspirational webinar. I think we have a really quick second. I just wanted to hear from you if you had any insights on caregiver networks or volunteers wanting to get more involved in some of this research and evaluation component when it comes to quality improvement in long-term care. Do you have maybe a couple quick tips that you'd like to share with us?
Yeah, absolutely. I think first and foremost, wherever caregivers and volunteers happen to be, you've got a very powerful voice for advocating for the presence of research in long-term care homes. I think that when we think about some of our large hospitals across the country, we think of those as places of innovation, right? Places that are exciting, places that attract the best talent, with the expectation that that continuous quality improvement and research or innovation are at the core of that work. I don't think that sentiment has yet made its way across all of our systems of care that provide long-term care. So advocating for our long-term care homes to be recognized equally as centers of innovation would really enable research. I think if you got specific ideas about research or evaluation needs, I'd be happy to be contacted to talk more about people's specific situations. Our research and evaluation team has really specialized its focus on looking at social relational models in seniors care. And so if that is something that is of interest, I'd welcome you to reach out. I'd be happy to hear from you.
Thanks so much, Amy. I'm sure the FCO team and many others on the call today will definitely reach out. So I just want to say a special thank you to our guest speaker for sharing such wonderful insights. And we do really hope the best for all of this research and work being done. I also want to thank our CARP Ottawa co-hosts, Carol and Margaret. Thank you for all you do, not only for our community in the sector, but for keeping so many of our networks informed and engaged on many of these important topics. I also want to say a special thank you to everyone for being present and interactive today. Our next FCO event is happening on April 30th, and it will be our spring town hall. So the link will be dropped in the chat momentarily. We will also have more updates on our town hall and other upcoming events in our e-bulletin as well. Another reminder that this webinar has been recorded, and the link and the recording will be updated within the coming weeks on both our YouTube page and shared in our e-bulletin. Thank you so much for your continuous interest in our programming, and we look forward to seeing you all very soon. Take care and have a great day.
Bye-bye. Thanks very much, Tiffany.
Thanks so much, Amy.
Have a great day.
You too.